This is week 18. Months and months have gone by, over 6 months. It's crazy how this virus has taken off. We are very, very fortunate tonight. We have two amazing people speaking. One is an old friend, Dr. Rafi Avitsian, who has been so committed to the education of our physicians in Armenia for a long period of time. And he hails from the Cleveland Clinic, where he's the professor of anesthesia, and we'll talk more into his background. And Dr. Yervant Zorian, a Ph.D. who actually trained in Canada at McGill University, where he got his Ph.D. And he'll be making comments about the CME program and sharing ideas about how CME can go into the multimedia realm to be much more effective in reaching target audiences in up to 7 languages. So we are very, very excited to hear his commentary as we move along this evening. Week 18, what do we see? We see back in April, the United States plateaued, and then we were doing really well. And then suddenly, with summer, we see a sudden steep rise in infections throughout most of the United States, fortunately not in the New Jersey, New York area. In 1 week, we went from around 40,000 to 100,000. So it really is spreading. As is the virus, this pandemic, it shows no signs of easing up. In fact, it's accelerating throughout the world. There's over 12 million infections in the world and over 550,000 deaths. The United States, 3.1 million and 133,000 deaths. And in Armenia, about 30,000 people infected and 535 deaths. How are we all doing as a country, and where are the hot spots? Well, the biggest hot spots, unfortunately, is Florida, where my son just moved to, Miami. So he moved from one ground zero to another ground zero for work. So we have a lot of concerns about that. And we see intensive care unit beds being taken up and many hospitals reaching their capacity. Texas is a hotspot, as is Arizona. But as we can see from this graph, most of the United States is not doing well. The only areas really doing well are the New York, New Jersey area and the northern New England states. So I guess we learned something from about social distancing and the need for masks, washing our hands, and not touching our faces. It's very interesting, you know, the average person touches their face between 25 and 30 times an hour. That comes from several studies, including one of medical students when they were observed. So again, we have to really have best practices until we have better treatments that have been implemented. But again, we're seeing strains on our healthcare system. We're also seeing strains with our personal protective equipment, which used to be in abundance a few weeks ago. We're having a harder time ordering it for our offices. The good news about Armenia is it's categorized in the Eastern Mediterranean zone. It's slipped from the number 5 position in daily incidence down to number 8. So that's encouraging, and we look forward to hearing more about that. In terms of treatments, we are hearing a little bit more about vaccines. Operation Warp Speed was designed back in April to find and expedite the vaccine development, 300 million doses of vaccine by January 2021. They initially looked at 125 vaccines. That number came down to 14 vaccines in May, and they've narrowed it down to 5, and they're pouring millions and millions of dollars into the research and also the manufacturing of these vaccines, even though they're not yet proven to work. Number 1 on the list is our Armenian company, Moderna. And then we have Pfizer's work here, Merck Sharp and Dohme, Johnson & Johnson, and AstraZeneca. Basically all the big companies. In terms of where we're going, Regeneron continues to make headlines every week in this space. They have 2 antibodies, which they put together as a dual antibody treatment. Phase 3 is now started this week, where they're going to enroll 2,000 patients and give it to healthy people at 100 centers throughout the country to see if it prevents infection. And they also are giving the dual antibody treatments to patients as outpatients and inpatients to see if it modifies the disease. So that's kind of exciting, and that might be here before the vaccine is. In terms of other treatments, hydroxychloroquine doesn't go away. It just keeps on coming back. There was a big study out of Henry Ford Hospital, 2,500 patients, peer-reviewed data that said hydroxychloroquine alone made a huge difference in outcome. But there were some criticisms of the study. And again, we wait more evidence. So again, it keeps on coming back and forth about hydroxychloroquine. What else is in the news? We heard that schools and colleges some are opening. I know Cornell, we got a letter from where my son has gone, and they're going to be having classes starting in the fall. They're going to use interesting surveillance techniques called pool testing, where they study vast numbers. And then if there's someone positive, they'll go back and study smaller numbers of students. There is a problem with online education. If people have visas and they're foreign students and they're only going to school by online, they will lose their F1 and M1 visa status. So this seems to be pushing people in schools to go to a hybrid where it'll be a combination of classes on campus as well as online. The US has formally begun process of withdrawing from the World Health Organization in the middle of the pandemic. And what else? There's controversy about flying. 700,000 people flew this last weekend. And the controversy really is, what do we do with the middle seat? And I hear on international flights, they are selling the middle seat, but it's really a question of risk, and is it really worth flying on planes? It's a very individual decision. So I'm going to give the call over to Dr. Celine Kojaglanian, who is a professor of infectious diseases, associate professor of infectious diseases at Maimonides Hospital. She used to be at Montefiore Hospital. She also is well rested after taking a well-deserved weekend off in the Adirondacks, which is in the Catskills, which is a beautiful place of upstate New York.
So this is a new tool that the CDC has, and it basically really, for those of us who are planning to travel within the country, is a great place and a very easy visual to see which are hotspots and therefore which areas to avoid, because especially for most of us on this phone call who are healthcare workers, when we come back from any of these states, for at least New York right now, has to, you have to inform your employer that you have traveled to these states. When you come back, you're obligated to take a test, and in some cases quarantine before going back to work. So it really has to be worth it to go to these places for, you know, non-essential business. So think twice, and at least New York State is constantly updating these red states where there is a lot of cases. So it's a very interactive tool and very easy to use for those of you who need to. And then I've been asked, obviously, every single time about testing. So this is, again, an updated New York State criteria for COVID-19 testing, and different states may have their own. But right now, we do have availability in the state. But the first sentence says that no matter whether you get the PCR test or the antibody test, you obviously need it to be authorized by a healthcare worker. And really, the basic stuff does not change. Someone who's symptomatic, someone who's a child who has MIS-C, someone who is exposed. So those things have not changed. But what has confused people, and I got questions from the clergy and other friends about this, is the last sentence they added, or a few words they added, that basically any New Yorker is eligible for testing. So now people are calling me, should we go get tested? So my recommendation really remains the same. I think this was Cuomo's attempt to say that the testing is available for those who need it, but just to randomly walk into a doctor's office and ask for a PCR is reassuring for only that day, right? So if you're negative that day, you don't have the virus that day, doesn't mean that you cannot catch it when you walk out that office. So we gotta continue doing the distancing and the masking. And if you do a serology, again, I've been saying this from day one, that we still don't have enough information on antibody or serology to tell us whether if we have it, it's protective. That means we're not going to get it again. So actually, there's a couple of papers that I shared with Dr. Bilezikian a couple of weeks ago that do show, one of them is from China. So anything that comes from China these days, we need to, you know, check ourselves. But one of them is from the Rockefeller Institute here in New York, where in a subset of patients, the quantitative level of the antibody decreases after about 3 months. So even those who had an antibody response and they were symptomatic, when they were measured again after 3 months, some of them showed a reduction in the absolute number. That doesn't mean, for those of us who are in medicine, that doesn't mean that that patient, if he gets re-exposed, will not necessarily have an anamnestic response, because we probably are building memory B cells, which hopefully should come into action if we get re-exposed to the virus. But right now, for the general public, again, I feel like unless your employer obliges you to or wants you to get it, there is no need to get it. But clearly, all the other criteria, whether you're symptomatic or you've had close contact with someone who has it, or you're in a healthcare, in a nursing home, and this slide can be shared with you guys if you like. And the great news that I want to share is that we just published, I was one of the authors, one of 3 authors who just published our pediatric experience in hospital pediatrics. And this is an official premier journal of the American Academy of Pediatrics. So this was a little nice, rainbow after a terrible storm, that at least our work is shared and by our colleagues. And it was picked up by CNN, which is a really nice thing as well, that they mentioned this, because it is in an American Academy of Pediatrics journal. It was picked up, and they actually did a very nice summary of what we said. And we basically, now that it's published, I can share it. And we basically said that during the epidemic, when we got hit in the beginning, the testing for children was exactly the same from criteria as in adults. So they were telling us, guys, don't test the kids unless they're coughing and having shortness of breath. So lo and behold, we found out that children actually do not have the same symptoms as adults do. So only about 30% of our hospitalized pediatric patients had respiratory symptoms, and the rest really had a variety of other symptoms. Some of them had just fever, a couple of them had seizures. We just admitted a patient today actually who also has a seizure from COVID-19. We had a couple of kids who had the muscle inflammation. And so basically what we're advocating in our paper is that in places where there is high community transmission or sustained community transmission, make sure that you test all hospitalized kids, no matter what their symptoms are, because that way you can isolate them, and so that there is no nosocomial transmission, and you can also preserve PPE, so that if you put 2 COVID kids together, then you will, not have to don and off the PPE that frequently. So this was a nice gift at the end of the exhaustion. A couple of more things I want to add is that there is, as you guys know, the remdesivir is really the only antiviral right now that is being recommended for hospitalized patients. But the point is that it was an intravenous medication, so it's really only for hospitalized. But now Gilead just started their trial with the inhaled version of remdesivir, which I think if it works, especially in the early stages, it would be a major breakthrough. So this is the new thing that I think was worth mentioning, the inhaled form of remdesivir. And then I'm not sure if you guys discussed dexamethasone last week when I was not here, but right now the NIH, the Infectious Disease Society of America, based on the British trial that has not yet been published or peer-reviewed, but it comes from reliable scientists, and it shows that in intubated patients with COVID-19, so those who are no longer in the viral replication phase, but they are in the inflammation phase, that it significantly helped reduce mortality. Although there is obviously problems with the study in that their mortality was measured at 28 days, and they still had more than 1,000 patients still in the hospital when the study, when the data was put together. So what's going to happen in that other 1,000 patients? Are they going to survive beyond 28 days or not? We don't know. And hopefully there will be a follow-up study looking at that subset of patients. And that's all I have to say today. I will take questions as usual.
Well, Celine, let me start first to congratulate you on this paper. It's
Thank
great
you
to
so
see.
much.
No, this is very important. It's a new syndrome, and you're at the you are on the front lines, as we've said so many times, and not just clinically, but also with regard to new information.
Thank
So,
you.
congratulations.
So much. I appreciate it.
Every week I seem to ask you the same question.
Yeah.
Let's get it to you. So I had a patient just a few days ago, and she said specifically she wanted to have a COVID serology antibody test that was quantitative. She said, doctor, don't tell me about plus minus, yes, no. I want to know what my titer is. And we know that the Northwell Labs gives you a titer. And we know that there's a threshold above which is positive and numbers below which it's negative. And I'm troubled by the threshold concept, because nobody should have antibodies unless they've been exposed.
Yes.
So how can they say, so anyway, please comment on this, because patients are very, they're knowledgeable. And I told this patient, I said, well, if you want to get a titer, go to a Northwell laboratory, and then we'll discuss it.
Yeah. Great question. So two things. Number one, if you remember, Dr. Veleziklan, way when the antibodies came out, we said that there is the positive predictive value of the antibody tests, right? So if you do it in a low prevalence setting, there is as much chance that an antibody could be false positive as it is in false negative. In New York, we are lucky that we have enough prevalence that we are assuming that all positive detectable antibodies, not the quantitative ones, but detectable ones, right? The qualitative ones are probably likely secondary to infection. So let's start from that most likely if you're seropositive, you got COVID-19. So as you mentioned, for example, a great example to give is varicella. We have never had success with demonstrating detectable antibody quantitatively after varicella vaccine, but over and over again, many beautiful studies have showed that if you do have 2 vaccine doses, you are immune. So you don't necessarily always rely on the quantitation of commercial antibodies to say that somebody is immune or not. So that's why I said earlier that just because the antibody titer is below the commercial market's number, where they decided that's a positive, that's a negative. So just let's say in your case, less than 14 is negative, above 14 is positive. So if this patient has 10, he does have something, right? So it's not 0. So it might mean that he either had the disease 3 months ago and maybe at that time he was 60, 70 and now he's dropping. Like I said, some studies are showing that there is a drop in the number, or that he didn't have a very robust immune response, but enough that he formed memory B cells and memory T cells so that if he does get re-exposed, hopefully he will not have the disease in the same severity. And that's really the $1 million question that we're trying to answer. And the third thing I would say is also depending on what antibody test is being used. So most of the ones commercially available right now are binding antibodies that are not against the spike protein. They are against another protein called the nucleocapsid. And why that's important is that it's really antibodies against the spike protein that are supposed to be neutralizing antibodies, because the spike is where the virus goes into the receptor. So that is really, I think, the next generation of antibody testing that's going to be much more helpful in telling us, how protective that antibody response is. So as far as Northwell, they do have 3 or 4 platforms. I'm not sure your patient which platform was used, but most of the platforms are still doing the binding antibodies to nucleocapsid. So that's why, based on everything I just said, we are neither the very high titers are very reassuring because they may drop after 3 months. And again, even if someone has 1 in 2,000 titer, I don't think that means that they should go out and, party and go to COVID parties, if that makes sense. So the data is coming out. We have a lot of new information trickling in, but hopefully what I said made sense or was helpful.
Okay, thank you.
That was a great answer. Just as a point of information, elective surgery in New Jersey started up about 2.5 weeks ago. It was going smoothly, but we're meeting a unanticipated problem. So many people are getting COVID testing, and the state mandates that anyone undergoing elective surgery has to have COVID testing within 5 days of surgery. And what's happening is we're not getting the results back until day 7 or 10.
Really?
At our surgical center, we had over 25 cases canceled last week. The good news is New Jersey State is watching this. We have to report every case canceled due to this, and I'm hopeful with discussions with our local state representatives that we will resolve this, giving some priority to people having surgery. So it is an issue when you're having elective surgery, so it's not all smooth sailing. Celine, there's one other issue that I've heard this week, and that is T-cell immunity. There's some questions that we're focused on antibodies, but there's a question of whether we have developed any T-cell immunity against this coronavirus.
Yes,
can you make any comments on that?
Yeah, so that's exactly what I said, that again, in those who have had symptomatic or even maybe asymptomatic disease, the asymptomatic is still a question. That there, like every virus, you always have the cell-mediated or T-cell immunity as part of our immune response to viruses. And so in varicella and other viruses, that's what we rely on, but unfortunately, that's not something easily measurable. So there is ongoing research to see how robust the T-cell immune response is for coronavirus. And even in those who do not have a robust antibody immune response, they could still have a T-cell immune response that will protect them against a second infection.
We're going to move on to our next speaker. As I said earlier, continuing medical education is a very interesting area. There are a lot of things that we all take for granted here in America. We take for granted that our physicians and other healthcare providers went to accredited schools and graduated, passed multiple board exams, and continue to update their knowledge through continuing medical education because it's required, it's audited, and we all have to be meticulous in following that. But Armenia really faced a difficult situation when it became independent with all of its other problems with war and earthquake. They inherited the Russian system, which was very, very good. But education, as we know it, didn't continue. And a lot of physicians continued their career for several decades without the benefit of continuing education. So there were several people who really fought for continuing medical education. One of the very, very early individuals was Dr. Rafi who was a physician held in high esteem from Indiana and then New York City, philanthropist, who we unfortunately talked about him as an obituary several months ago. But he was a very early proponent for this. And in fact, he helped AAHPO start a CME program in Artsakh, and he then went on to expand it to the nursing program. And in fact, he felt so important about this that this program is going to be living on in his name. Parallel to that, the Fund for Armenian Relief has spent many, many years developing continuing medical education, even when it was not required. In fact, Fund for Armenian Relief has created over 100,000 hours and AAHPO over 33,000 hours. In addition, we are very, very fortunate to have many talents in the Armenian community, one of them being Dr. Rafi Avitsian. He always dreamed of this as well. And due to his efforts, largely, the Center for Professional Development, International Center for Professional Development, just was brought to life only a few months ago. So it's really very, very exciting to have him here with us to talk about this. Rafi is a great friend. He's a great father, great husband. He also is a professor of anesthesia at the Cleveland Clinic. He is the program director for Neuroanesthesiology Fellowship Program, and he likes to start new organizations. So he's also the founder and as well an executive board member for the International Council of Perioperative Neuroscience Training. I can also tell you, I once had an experience putting together a AMIC, the Armenian Medical International Committee in New York. And I hadn't known Rafi at that point. And someone said, call Rafi, see if he can come. The meeting was going to be on Saturday, and it was like Wednesday, and he's in Cleveland. And when I told him, he said, no problem. I'll take a flight. Just meet me at the airport and bring me to New York. That's his spirit. So without further ado, I'd really like to introduce all of you to our friend, our colleague, Dr. Rafi Avitsian. Thank you so much, Rafi, for joining us. And you can set up screen share. You're on mute.
Thank you very much, Larry. It's a pleasure to be here. When it's like an interactive question and answer, but then I thought I shouldn't be lazy. Maybe I could share a couple of slides that would give you the history of what ICPD, or International Council for Preoperative, International Council for Professional Development, is. As Larry said, the history of CME in Armenia is pretty novel compared to other places. And that is because the medical education in Armenia has been the remnants of previous Soviet until early 21st century, that the doors opened for communication with other medical schools and medical education systems. And that was, in fact, partly because of the efforts of some of the leaders in the YSMU, including at that time the rector dean, Dr. Kalyan, as well as vice rector, Dr. Yervant. I always say the story, it was about Linda, my residency, when I sent an email, found out that there is an Armenian community for physicians in Armenia, sent an email, and within the hour I got an email back from Kerouac saying, yeah, we would like to collaborate. And that started the whole story. Unfortunately, as it's still being seen, the leadership at different levels changed in YSMU as well as the Ministry of Health. So it was difficult to have a long-term continuous planning. But having said that, I should say what my interest is. My interest comes from my passion in education as well as passion with Armenia. I have had multiple visiting professorship trips, as Larry said, as well as I have had a lot of observers coming to Cleveland Clinic to see our facility. And my point was not exactly just showing them how a surgery is being done or how anesthesia is being used, to see the system. So when they went back, they could renovate the medical system as well as the education there. Well, along the way, there were a lot of successes and there were a lot of failures. So there was a lot of lessons to be learned. But there were three important things that I really wanted to achieve in Armenia. And this was the goal from the start for me. One, curriculum development for each specialty, the way that most of the Western world has it. Number two was licensure. A physician coming out of a medical school should have a kind of a licensure. And three was the continuous medical education. I'm not saying none of these was there, but it really needed a revamping, like many other industries in Armenia. The proposal that I had given at that time, and in fact, we discussed this during the AMIC meeting, I don't know if it was in New York or in Florida, maybe more than 10 years ago, was having a three-pronged approach of our role as far as the physicians or physician educators in diaspora, as well as the Ministry of Health and YSMU, to have some specialty licensure. Some of them who are there could be grandfathered, and they could help in curriculum development. And we can help them in curriculum development. There should be a CME system that should be overseen by YSMU. And those of us, in fact, who do have some experience in creating CME. This proposal was presented, to some extent, it was welcome. But it was about the 12th International Armenian International Congress that in Buenos Aires that I presented 2 panels. One of them was the plenary session about current health situation and health education in Armenia, as well as I also provided a study of comparison of Western and Armenian medical education systems. And that was with a medical student as well as Dr. Yervant. In that, we were looking at the differences in geography, economic development, size, as well as sources of education. And the focus was on curriculum and licensure with CME, which was provided, and showed a huge difference between the countries. And some of them, Armenia had picked up a few things here and a few things there, but there was still was a need to put them together and make something that fits the Armenian system. Now, the Cleveland Clinic also has this international physician leadership program. Some of the key people who did come to that program was Dr. Zorian from Ministry of Health at that time, and Dr. Yervant. And it started percolating some ideas within them. So finally, a couple of years ago, CME became a mandatory thing in Armenia, and that is to start in 2021. Now, the thing that I think is missing is how to get that CME. So you can make something mandatory, but you also have to give the opportunity to get it. Now, the very important part in here was some of the diaspora or Armenian physician communities in here, including Rafi, as well as AIMS, as well as some in Europe, that collaborated with FAR and brought some very good continuous medical education, especially for those who were in the regional parts of Armenia. However, it is also needed some revamping to go to the next level. So why am I saying this? Because I'm sure many of you have visited Armenia many times. You have seen the differences in a lot of other industries. So remember in year 2000, 2005 when you went there. Remember when you, 2010, then 12, 15, you notice that there's a big rise in some of the other industries, including tourism, including the restaurants, everything else, IT, with the tumor center and everything. But there is a little bit lag behind in the physician education system. It's still there, but we need it in a higher level. That's why we came up with the development of a center, the idea for implementing the multidisciplinary simulation center. This was at first an idea that went onto paper. That I was there, and Yervant was on it as well. Now, this idea also included, developed into a larger one for a multidisciplinary, multi-specialty continuous medical education center in Armenia. But that needs money as well. So it was a big, huge business plan. We needed some cooperation. Some people in the Ministry of Health were very much in line. We really needed some push and help from outside of Armenia as well. And at that point, some of you remember that I got in touch with you and discussed the ideas and how we can create this. So creating a centralized CME center was another article we came up with, which had a mission, and the mission was the CME project to improve healthcare for Armenian population. It had a vision as well as objectives. So these are the important parts I want to show in that original idea that we've given. It can impact the economy for Armenia because there would be jobs created. So it's not only that the physicians would get their CMEs, it would bring in people from outside to get their CMEs in Armenia. So again, the comparison, you go to a restaurant, it's like a family fast food restaurant. very good food, everything is fine. And I'm comparing that with the current CMEs that are being offered to doctors there as well as regional. But still, some doctors want to get a very high level. They go to Austria, they go to Germany, they come to the United States or Russia and spend a lot of money. And this compares to that very high-end restaurant that now we have in Armenia and Yervant. And people want to go there, they can go there. So how can we make this type of CME market there as well? Well, the founders of this ICPD, I can say, at least with the idea was Yervant and I, but then we needed someone internal who was powerful enough to have their work done. And that was when Dr. Pavlioyan as well joined. We came up with a vision of making Armenia a regional frontrunner in healthcare science and technology by continued medical education, affordable for them, but high enough quality that people from outside would also come. We started writing the bylaws. The bylaws are in Armenia going under review to make the ICPD as a nonprofit organization. We do have an executive council, and I am happy to say that Dr. Bikin Sepalan has also agreed to be on this council as well. So in a nutshell, the International Center for Professional Development is created with the goal of providing resources for continuously improving the knowledge in the healthcare industry as well as biomedical technology. It relies on live conferences, modules, workshops, and these resources not only serve to improve the knowledge of many Armenian physicians, it also creates networking with internationally very well-known physicians as well. The first conference was supposed to be right now, actually today, in Armenia, but unfortunately, because of the COVID-19, it got delayed. So what we did, we came up with the idea of having the virtual one, like AAHPO is doing, like AMIC is doing, like EMS is doing, and we partnered with this group called Skill in Armenia to have online virtual meetings. And with that, we partnered with a few centers to see if they can help us go in that. And found some very important sponsors, including games, and the main essential partner was FAR, because they have the experience, they have the knowledge as well as funds. We also have other sponsors, including Pharmed, Arabgear, Yervant, and a few others that are helping us, not only for these upcoming conference, but also for the whole idea of ICPD. So the upcoming first one is tomorrow. Tomorrow, 9 o'clock a.m. In Eastern time, and that is a 1-hour roundtable about COVID-19 with the Chief Clinical Transformation Officer for Cleveland Clinic, Dr. James Merlino, who was on CNBC recently, pretty close. And the other participants are going to be the heads of the hospitals in Armenia, which are involved in COVID-19 patients, as well as the Deputy Minister of Health. If you can join, just go ahead and register. If you cannot, it's okay. It's going to be recorded and then be available in both languages. This is the website that you can go and register for it. And that's tomorrow, 9 o'clock our time, 5 o'clock Yervant time. The next one, and we're very excited about this because we can see, as you see, some of the speakers are from AAHPO as well as from AIMS and other places. And it's a virtual one-day conference about COVID-19 pandemic and the lessons that we've learned from it. And that's going to be July 25th. We are trying hard to get the CMEs for it, both in Armenia as well as US. And the registration is free. So you can get free CMEs if you register. Hopefully, if we can make it on time with the assistance that AIMS is doing for us to get the approval for US CMEs. So just the slide, last slide for future, we were planning on live conferences as well as virtual conferences, as well as hybrid conferences as workshops. We do want to collaborate with the other industries, including tourism, for a medical education tourism, as well as collaborate with Ministry of Health and initiate the maintenance of certification there, as my goal has always been like that. And thank you very much, and I'm sorry it took your time too much.
Rafi, is tomorrow's conference going to be recorded so we can
yes. So
log
it
in
will
later?
be recorded. Yes, it will be recorded and will be available on YouTube and Facebook as well. And Skill is doing that.
Facebook, does ICPD has its own Facebook page?
It is, yes, it is.
Okay.
I don't have Facebook, I'm sorry. I'm mostly.
No, it's okay.
Yes, they do have it. It's, I think it, if you search, it's called ICPD Armenia.
Great, thank you.
But the information, everything is on that website.
Great.
Rafi, congratulations, and persistence pays off. Great job. Do you foresee the ICPD developing CME content, or do you see organizations coming to you for approval of content that they've developed?
Both. So if I heard the question right, is it involvement in providing the already existing CME or making CME? And I think it's both. I mean, it is not one specialty. It's the success on this program is going to be in involvement of different organizations. Look at it. Zorian has just published something very famous. We need to see a lot of people that are really, really working hard and at the top of their specialty. They are the ones that have to come in and help for the project. It's nothing to take credit on this. It's just collaboration between different specialties to have the top of the notch education material for the CME. The plan that we have is to make a profile. So if you register, you will have a profile for yourself and put all your CMEs that you have registered and bought or participated in there, so you can have a reference to go back and look at it later on.
And all CME that is awarded and recognized in Armenia has to come from this organization?
No. We, it just like USA, they have a system for their CME, and whoever has an educational program has to apply for it, just like we do in here. And there's certain criteria that you, including the conflict of interest, disclosures, who's the speaker, what's their bio, so on and so forth, for that program to be able to give CMEs. And we want to be the best, but we are not going to be the only one.
I see. Rafi, you'll take a few questions now, and then I'm going to introduce Dr. Zorian. But does anyone have any questions before Dr. Zorian comments on this? Go ahead, Salma.
Hi, thank you so much, Rafi, for the great presentation. Hi, as far as I know, NIH in Armenia is the center that provides continuing education. I'm talking about nursing now, for nurses. And they work with a European department somewhere in Europe, I guess. And so this center is then going to collaborate with NIH, with the European, or it's going to stand alone with NIH?
Sapi, I didn't have time to go into details, but at NIH was the first place that ICPD went to and said, hey, we have this idea, what do you think about it? And they said, okay, let's see what you do. So they saw that we take it for serious. The first conference that I mentioned, the anesthesiology one, we had applied for European CME, EU CME. It's not that difficult to do. It needs a lot of paperwork. If you think the US has a lot of paperwork, look at that. But we were at the verge of getting it when the COVID came. NIH is not the only place that goes to Europe. Someone else can go to Europe as well. And you can have an online application to get CMEs for countries which are inside the EU.
I can add something. This is Georg Gerjan calling from my phone. So how the system is work? anybody in Armenia can provide conferences and apply for CME credit. So 2015, the National Center of Accreditation became available for Armenia, and actually we put a lot of efforts to create this center and write all bylaws. So if I'm not mistaken, Dr. Sepelian invited Dr. Sona Sarkisian, director of this center, to make a presentation about the credit law in Armenia. So she will be on one of the next round tables from AMIC organized. So anybody can apply to this organization and get a CME credit. It's a lot of paperwork, as Rafi informed, but also anybody can go and apply to the European organization. It's called UMS. And actually we have a very good connections with UMS because we already provided a few credits via AMIC conferences in the past. So we will apply for anesthesiology conference to get European credits, but also we will also try to get US credits. So anybody from Europe or US or Armenia who will participate in our future conferences, they will get credit accordingly, their rules.
Thank you, Kevork, for the clarification. That's exactly what I was asking, the European component of offering continuing education. And when we do the ENT conferences, that's where the SONA organizes all that. And then the physicians get it. And when nursing does conferences, we get it also from NIH through SONA. So there is a system. It's wonderful to see, though, the US coming into this whole picture, because that, I'm sure it will give a lot of, I mean, I don't want to be biased, but it will give a lot of credibility for the continuing education credits. So thank you.
Great. There's a question from Dr. Bill Avitsian.
Yeah, Rafi, thank you for that presentation. And this is really a big step forward. And Gevork has worked very nicely with you to get this set up. I have a practical question. Every year, but not this year, I do have a CME program, and we draw about anywhere from 800 to 1,000 local Armenian healthcare professionals. And it's a metabolic bone disease program, but the subject isn't important. We do all the paperwork, and it is through the Minister of Health, and we do it. What are the advantages of going to you and saying, we're going to do this, and we'd like to work with you, versus doing what we've been doing right along independently?
Well, I think that's an excellent question. And in fact, I wanted to convey the message that it is there. We already have people doing wonderful work. We just want to step it up. Now, today, if they have 800, 500 people joining within Armenian regions, it's good. How about involving people coming from Russia, Europe, Iran, England? Because it's such a high level, and Armenia is such a nice place to visit, for them to come and listen to that and get their CMEs. So in fact, it is moving up a notch, involving more of current speakers, being able to give them honorarium to come, paying them their visit, because a lot of us up till now would not going to be able to do that because they're expensive. Now, if we have registrants from Paris coming, we have registrants from Germany coming, because it's good, why not do it?
Yeah, no, I understand. This is very good. So it really, the notion that Armenia, a lot of us have hoped that Armenia would become a center of this, a center of that, and you're talking about it becoming a center of CME, not just for Armenia, but for, a much greater border, in fact, no border. The world could be all focused on Armenia. That's very good. Thank you.
Talking about Armenian innovation and being better than ever and reaching high, Rafi, we are just so honored to have Dr. Yervant Zorian with us. I just met him yesterday, and I want to thank Anita Ansarian and Natalie Gabrielian for introducing me to him. I reached out to both and asked them if they had any comments about tonight's talk, and they independently both said, you have to talk to Dr. Zorian. And he was so kind to share his story with me last evening. Really an amazing story. And, it's interesting. We all live in our own little silos or worlds, and I think the real value of tonight is we're reaching out to two different worlds, and maybe something interesting can happen. Dr. Zorian was enlightening about how he started and founded and runs the Armenian Virtual College in Yervant that now hires over 50 people. He is a member of the central board of the AGBU, but he's really a rock star in the technology world in Silicon Valley. He is the chief architect and fellow at Synopsys, a high-tech company that supplies the building blocks in everything that we buy commercially that involves computers. He also created a division of that company in Armenia, hiring Armenians and working in Armenia. He has other accolades as well. He is the president of the IEE Test Technology Technical Council, and he's over 35 patents, has authored 4 books, and published over 350 refereed articles. So he's catching up to you, Dr. Avitsian. But I'm just so excited to hear Dr. Zorian's comments about multimedia teaching efforts with his platform, with multiple language, with international appeal. And it sounds just like what we're trying to do here, Rafi. So without further ado, Dr. Zorian, thank you so much again for joining us. And if you can unmute yourself, we'd love to hear from you.
Very good. Hello, good evening. It's my pleasure to be with you. It's a very exciting program you're introducing here. Rafi, I'm very pleased to see you establish such a nice program with the team for education. Though I come from the IT domain, the semiconductor industry, in the chip domain, but I also have education as a nice hobby for me. But a certain angle of the education, it's more the educational technologies. It's more how we can use the virtual world in education. And it started from my Armenian angle. So what we have noticed some time ago here in Silicon Valley, since we don't have any Armenian schools, our kids were growing and we needed to give them Armenian education. So back 15 years ago, we noticed that our kids are doing online courses. They're doing some digital knowledge transfer, interactions, and so on. We wanted to create an Armenian virtual knowledge base and Armenian virtual networking possibility. So our experience comes from there. So we leveraged what the education technologies provided us and still provides. You know, this field has been moving very fast. I'm sure many of you are following it. You're doing virtual conferences now. I'm very happy to see that, workshops, and expanding your arm via virtual means. So we also noticed that back at that time and started venturing into it. Initially with just the digital world, digital multimedia that is bringing not a single media, but bringing the audio, the video, the text, the animation, the sound, and so on. Now we moved from multimedia to this online interactivity, which is very important because you don't want to learn in silo, but rather to learn in multi-direction with your teacher, with your instructor, that is, with your other students. All this peer-to-peer learning today is in multi-directional. And the online world provides us that peer-to-peer learning. So we moved from multimedia to multi-directional to multi-devices. Today, you see learning is not only on the computer, it's in any device that you would use, from the large screen to your handheld small equipment, and more recently into your goggles, into your virtual world, virtual reality or augmented reality. So education is in the forefront, right? It's moving very fast, and all levels of education, from elementary schools today to high schools, universities, and most importantly, training. In Silicon Valley, 98% of the companies use virtual training to retrain their employees. We have mandatory courses we have to offer to our employees. We have optional courses. All of that is done. All that training is in virtual means. So today I thought maybe commenting about that virtual way of training would be an angle that you may want to look at. Though currently you're looking into a face-to-face training, which is important, bringing people to Armenia, which is important, helping with the tourism, helping with the targeted tourism, in this case, training tourism, I would assume. These are very good things, of course. But one can expand the opportunities far more if one uses the virtual world. So e-learning courses are not very difficult to create. Multimedia courses, that is using animation, videos, audio, and so on. And we do that production today for the Armenian Virtual College in Armenia. Armenian Virtual College, which we started back 15 years ago to prepare it, and 10 years ago we opened it to the public, is an AGBU initiative, is an AGBU institution today. Within the last 10 years, we reached up to more than 25,000 students who are learning Armenian topics. So this Armenian Virtual College mainly was for Armenian topics for Armenians. So language, history, heritage, culture, architecture, music, and in 7 different languages. All this interactivity with peers, with teachers, all what I mentioned is incorporated into the Armenian Virtual College. To realize it, we used the tech sector in Armenia. So we leverage the talent in the IT domain, we leverage the pedagogic talent in Armenia, and the content providers, topical. And today we have variety of courses, and of course, if you're interested, you can check out the Armenian Virtual College. The reason I'm bringing it here, because creating such courses are possible. Hosting them on learning management systems, where you can have your lessons, your interactive sessions, your Zoom sessions like this, your calendars, your exams, your tests, your interaction between the learners and the instructors. All of that can be in one place and can be available anytime, anywhere. Meaning, if I want to learn in the morning or in the evening, if I want to learn from Artsakh or from Vernatsor or from Moscow, I will have access to the same information as long as I have internet, as long as I have access. So we are using this today, not only for Armenian topics, but we expanded it beyond Armenian topics. We went ahead with chess, for instance, and we're offering now chess as part of our program worldwide to many countries, to many students, for students. We're preparing a chess for teachers program to train teachers, to prepare teachers. We are working on AI, artificial intelligence courses for the high school level students. We are working on entrepreneurship. HBU has this women entrepreneurship program, which also has prepared its content. And again, it's hosted and made it enable via the learning management system that we have. So this is just some examples I wanted to maybe share with you, thinking that perhaps, if you want, I know in the medical field there's a lot in the virtual learning domain. Lots of things are moving towards that, but perhaps your CMEs at some point you may be interested in looking into that possibility. Just I wanted to provide my input in this domain. Thank you.
Thank you very much, Dr. Zorian. I think that was a very important point, that world is moving ahead, and virtual meetings, virtual networking is a very important part of it. We see now in universities, a lot of college students have changed that to virtual meetings. There are obviously some elements of it that have a less of a effect, including some workshops that are manually training. But even for those, there are some specified programs and simulations that you can do via networking and computers. And in fact, this was the question when Larry asked about, so what was the COVID effect on the program that you had? Said, well, we learned from it. It was a bluff that did not work by that virus. We saw the bluff and we played against it. Now we have virtual meetings coming up. Having said that, even that can bring tourism, not necessarily actual people going there into Armenia, but opening up opportunities for any other industry and business to know virtually where and how Armenia is.
Yes.
That is why when we started, we said, okay, so let's see which company in Europe or somewhere else can help us do the virtual meeting, which actually I said, no, let's look inside Armenia. Let's see if there is a company which will do it there. Unfortunately, there was. This company, Skill.am, has been very, very helpful. Their technology is, well, may not be at the Silicon Valley, but it is internal. And let me tell you, the price is also very, very different. And that also gives them another opportunity to expand job opportunities inside Armenia too. And I agree. And I would like to be in touch more and go into some more details, including some workshops, point of care ultrasound, for example, or those that you can do virtually and teach people in Armenia on how to do it. And I think we can get somewhere with this. Thanks for the comment.
Very good.
One thing that I was having a hard time wrapping my head around as I was speaking to Dr. Zorian is he was talking about these educational programs and animations and teaching modules, feedback, interactive, and virtual workshops. And it was so different from the CME that we're used to. You know, we're kind of stuck in, doctor gives a lecture, we maybe give a quiz, maybe ask a question, do a survey of the group. I think Dr. Zorian is referring to really a multi-dimensional CME program. And then, you know, I started spinning my head, how is he going to do this? My God, you know, that takes a lot of expertise. And Dr. Zorian, if you can share with us your team of 50 employees, how they divide up and how they actually get that product that seems so attractive for people to come onto.
Yeah, of course, of course. Yeah, so we divide it, at least in terms of domains, knowledge domains, to three groups. One is the content-oriented team. If we're doing language courses, you need the linguists, the teachers to do that part. Or music, you need the music historians or the chess experts. So the content providers is one aspect of it. We have clear requirements for them based on this second domain, which is the pedagogy. The pedagogic aspects in virtual learning are quite distinct. They're very different than our face-to-face classrooms. Face-to-face classrooms, we have certain, 45 minutes classes, certain interactivity, teacher-student environment, and so on. When it goes to online, things are different. Yes, you are using multimedia, which makes it more interesting, but then the learner is alone, is in silo. Yes, you may have synchronized classes where others are present as well, group activities, but also there are possibilities where you're doing it by yourself. That's why animation is important. That's why short segments are important. From our experience, even if you have a 30 minutes long presentation, we divide it to 3-minute segments, not longer. Every 3 minutes with multimedia. So you have voice, activated, animation, visual material to go with, but every 3 minutes you have a short questionnaire, very quick quizzes, multiple choices, you interact, you react. Then you go to the next step, again, your animations are reactive as well. So you want the class or the learning unit not to be one way, you need to be two ways. So the learner need to interact with it continuously. So with 3-minute segments, with multiple questions in between, you can be engaged throughout. So we measure the engagement level. You want the person to start and finish. We call it the retention, right? So end-to-end retention within a lesson. Then you end up with certain activities. Then you end up with one-on-one with your instructor, and then group activity to follow as well. So we believe in this reverse learning. When you see your lesson before you go to the group, when you learn and then you move to your group and you do your interactivity later on. So the second aspect, therefore, was this pedagogy. Now, in order to build these elements together, we need a software, you need an IT, a technology team. And a technology team collects all the material and creates the necessary animation, puts the audio, the video, the text, and so on, and does the multimedia package for it. It's an activity that needs software knowledge and so on. We do all of this in Armenia. We use the talents from Armenia to develop the courses. We have, of course, all the way to the documentation, to the quality assurance units, and so on. It's like a startup. It's an HBU operation working like a small startup company doing end-to-end production. But production is only one part of it. The next part is the service. So it's product plus service component. The service being during the delivery of the courses, you need to have your instructors, you need to have your IT support, you need to have your registration, your database, your marketing and messaging, your community partnerships. So there's an operation unit as well. So the 50 people that I mentioned does have that as well. Now, one component I forgot to mention so far is the language aspect. Now, because we're teaching topics, start with Armenian topics at large, say Armenian history. We have 7 courses in Armenian history, but in what language? Being 10 million global Armenians, we need to use multiple languages. Unfortunately, we cannot do it in Armenian, as now here we're speaking in English, but we have people who don't know English, they need it in Russian, or in Spanish, or in French. So from day one, with virtual college, we decided that we'll be using 7 instructional languages. So any course, whether it's history, architecture, music, language, or chess, it comes in 7 flavors. So you choose if you want to do it in Spanish, French, Eastern Armenian, or Western Armenian. We consider them one language. Turkish or Russian. So you can choose which one, and you do it that way. What I'm saying this because that has also a dimension or an effort associated with it. So every content that we prepare, we need to translate, we need to edit, we need to narrate. So you need the narrators, you need the speakers with the right pronunciation, with the right level of sound, and so on. So we try to do all of that in 7 languages. So in the team that we have, in the production team, we do have people who have these 7 languages in terms of separate translators, separate editors, narrators. In the service team, we have online instructors with these 7 languages as well, okay? So we have a person from Spain doing the instruction in Spanish. We have people doing it in France, in French, in Turkish, and so on. Therefore, the audience that we have, the population that we have today from 106 countries accessing online, they choose which language they want, and they belong to virtual classrooms using that instructional language, okay? So this shows us a little bit about the division of effort, if you want, behind the scenes in making this product and service happen.
One thing I want to point out, and this has been a thought with our group, is the human touch. And most of the physicians online will probably know what I'm saying. When we were young, when we were, I don't know, trainees, newly out doctors, we made a poster. We were so happy about it, stood beside the poster, and this so-and-so professor passed by and looked at it and gave us some direction, and we were so excited. And believe it or not, we do have a lot of good abstracts coming out even now when we go and have a one-to-one conversation to a young doctor. Now, what I would like to suggest in your program, and we think that we can do this also virtually, is to have a one-on-one mentorship. So virtual mentorship is something that can become a reality and help people in Armenia. A lot of people there want to come out and come to US or European or Canadian institutions because they really need that one-to-one. They really need that education. One very interesting thing that I saw early on was when people came as an observer to our institution and looked at me talking, teaching our trainees. And they were so surprised. Oh, you're teaching this to them? Then they will know it. And I said, that's the whole idea. So I think we should encourage that culture of mentorship and teaching, even virtually as well.
We're very fortunate tonight. We have Dr. Dick Babine with us. He was the chairman of the urologic department at Boston University Medical College. He also was the president of the American Urologic Association. Dick, can you share your experience with us? There was a program that the Urologic Association had for training physicians. Can you tell us a little bit about your experience with that program?
Sure, Larry. When I was president of the AUA in 2017, I wanted to take advantage of our specialty society's Office of Education, which had what we call the American Urological Association core curriculum. And it was online and it was available to every urologist and urology resident. So what I did was I was able to get online membership to take advantage of the AUA University for every urologic trainee in Armenia. So they were able to go online and get the same educational benefits that US residents get. And every September, the Armenian Association of Urology has an annual meeting, and every other year, urologists from the European Association of Urology come and do a 2-day seminar, and Americans come every other year. And we have about 52 urologists in the US and Canada of Armenian descent who have taken part in this. Some have made contributions to get the online membership for the residents. Others have gone to Armenia on multiple occasions. It's a small effort, but I think it's bearing some fruit. The problem is that the residents need to be conversant in English to take full advantage of it.
And I hear a lot about surgical simulation. When we were training, it was see one, do one, teach one. It was a gradual process of increasing responsibility, but now there are surgical simulators. Is it feasible working with this program that Rafi's setting up and possibly using Dr. Zorian's technology, that we can bring surgical simulation to the various medical specialties to Armenia?
That's a little tougher area because of the variety of different surgical techniques. Some lend themselves to the virtual simulation world, others do not. The ones that would be best suited, unfortunately, are the highly technical and very expensive procedures such as robotics, which Armenia doesn't have much in the way of, and it would be a very limited audience.
Actually, thank you for all the speakers tonight, and especially to Dr. Zorian, who was in Toronto a year and a half ago, I believe, and he gave a very good presentation about the program. And at the time, it was very nice to hear about the students who get enrolled in this program. I wonder whether if it's possible to give an idea of who the students are. And during COVID-19, during the pandemic, is there an increase in the enrollment of the programs in every sense? Can you please give us a brief idea of what's going on now?
Thank you so much. Yes. Okay, so let me talk about the students a little bit. Unfortunately, today I'm doing it as a comment, but one day, if some of you are interested, we'll be more than happy to share with you not only some demographics, but also some samples of the outcome. You may be interested to see when I'm speaking about the multimedia, interactive, moving maps or pictures. You may want to see the dynamic part of it as well someday. So we will think about that as well. Now, to the students. What we did is we started with the diaspora at large and started augmenting it. And being online, everyone who has access to online mechanisms started to come in. So initially it was the communities where AGBU has presence in, especially the Western-oriented diaspora, if you want, whether it's Middle East, Europe, the two Americas. However, soon after, we started seeing small communities from different places that do not have any organization, any structure, any school or church. Examples of which are, I know, the community in Venezuela or in Johannesburg or in Shanghai, in Hong Kong, elsewhere. So we started to see lots of small communities coming in and embracing the program and starting to come in. So today we have students from 106 countries, as I mentioned, in variety of ages, but most importantly, the younger ages. So we have the younger ages up to 20 years old. They make about 30% of our population. And then we go slice by slice until the highest age, I wouldn't say oldest, but the highest age would be 88 years old, a dynamic student who's learning the language and so on. Now, besides the age and the country distribution, it may be worthwhile also mentioning what they are studying. So about 2/3 of our students are doing language, half of them Western Armenian, half of them Eastern Armenian, some of them doing few courses, and some of them going all the way to master's degree, okay? So we are AVC, the Armenian Virtual College is an official university in Armenia. It has its accreditation by the government, by the Ministry of Education. It gives 2 types of master's degrees in language and in culture. Okay. The other small angle that worth looking at is that not all the students are from Armenian origin, okay? But they have interest in Armenian topics. So 10% of the students are non-Armenians by birth, okay? For family reasons, husband, wife, girlfriend, boyfriend, or business reasons, or cultural interest. So we have about 10% out of our 25,000 learners do belong to these groups. One more point of data may be worth mentioning is that even though we started our program initially for individual students learning by themselves at their home, as we're doing today, accessing internet individually, we saw interest through schools. So we do have a good number of schools today, Saturday schools, regular day schools, Sunday schools, who come as a group. We call that hybrid, of course. Hybrid because you have the face-to-face component with an online content, okay? So we have today 30 separate hybrid programs all over the world, from New Zealand to Buenos Aires to Paris, Geneva, Lyon, so all over. So 30 schools that are following our program. And what we do is, again, it's not individually giving them knowledge only, but rather linking them with each other. So the essence here with the virtual world, in order to break the isolation, is to spend half of the time individually taking the content, absorbing, learning, and 50% interactive communication with the teachers, with the other students, and so on. So that 50-50 is an important component. So we have, therefore, a very good number of students who are part of the school system in these 30 different hybrid programs, including some universities in Europe, in the US. Now, you had a question also about the COVID and the impact of COVID on our program. We had impact in 3 aspects. One is that the number of students or the number of learners in our quarterly learning windows increased 4 times. So, which is great. 400% increase was a lot, due to the fact that people are at home, due to the fact that we were able to to reach them in much stronger way through the Ministry of Education in Armenia, through other communities and liaisons throughout the world. So we did a major campaign, and we had 4 times more students in spring and now summer as well. But this is for the regular courses that we have. In addition, we created few initiatives. One of them is something that you could also, if you're interested, participate. We call it the Armenian Learning Zone. It's not a course, it's a learning zone about Armenian heritage topics. And every topic, we have lots of multimedia material, one can go through it, and it ends with a live session where an expert would come, like this here. We'll talk to a group of people in different languages also. So in this learning zone, every time we go to somewhere and we learn either a city. We were in Ani last week. We were in, we did various topics. So we're going to Akhtamar next week. We do the architecture part. So it's nice. It gives you the heritage coverage per topic. So we have done 25 visits so far, 25 episodes, and we're continuing. So if you're interested, again, you can check it out. It's free of charge. You come in, you see the multimedia, you join the live session at the end, if you're interested, of course. The last one I wanted to mention is another initiative in our chess work. Again, because of COVID, because of isolation, students being somewhat at home, there are lots of chess-loving teenagers, students or school kids in Armenia and abroad. So what we did is we initiated 4 weeks ago this Pan-Armenian chess tournament, totally online. It's a chess tournament. We partnered with the Chess Academy of Armenia. And then we made an announcement for students from all over. 18 years old is the age limit. And we got 520 students, teenagers, to join, to compete. But not only to compete, so we gave them, again, a special page, lots of activities, meeting champions, doing master classes, taking the last hour lessons as well, and so on. And then we did regional semifinals and then the total finals. And we got all the ranks and so on. I'll be happy to share that with you also if one day if you're interested, or you can see it on our website. So this Pan-Armenian chess tournament ended last week with all these 520 students coming into a closing session where, again, interestingly, the Chess Academy helped us a lot. We get chess masters to be present from all over the world, Armenian chess masters. So we had 23 chess masters from around the world coming in, from Brazil, from Belgium, from Spain, from Russia, from Ukraine. So they came in, and also they took their part. They had some games against each other and so on. All of that, not to find out who's the best chess player. All of that is to create a community. Today, we have a nice community of young Armenian chess lovers. It's a virtual community. They have their own page. We give them activities every week, and we keep them as a virtual community to learn, to network, and to build Armenian relations with each other. It's just one example. So it was a long answer, Ms. Avitsian.
That was a beautiful answer.
It is. Thank you so much for all the details. All the best. Good luck.
Thank you. Thanks a lot.
I wish I was less than 18 so I could join this chess club. But Dr. Zorian, hypothetically now, let's just say we want to start a 4-hour CME course, and we would just get maybe a plenary speaker. We would create a session with 3 or 4 speakers, and then maybe another speaker and mix it up a little bit for 4 hours. How would the Armenian Virtual College design that same 4-hour program with all the different multimedia abilities that you have?
Okay, let me put a scenario. Let's say you have this 4-hour program. What we would do, quickly thinking about it, we'll divide it to 8 units, half hour each, to make it easily digestible. And this, each one of those half-hour units will be segmenting it to shorter pieces. So the speaker can speak, but while he's speaking, as I mentioned, those 3-minute segments. He will have with every piece that he is presenting a visual component to go with it, whether it's animation, it's dynamic or static, pictures, videos, and so on and so forth. So you would have half hour divided to 10 small segments with multimedia elements. You would see the person initially, then you don't necessarily need to see that person all the time. You may see the visual material and you have the sound behind it. And then every 3 minutes, you have a quick quiz to make sure that the person is following and is moving from one segment to the next one. And then you decide how often you want to open those 8 lessons. So you have now 8 lessons. We can host them, or you or AVC can host them, can help produce those first, and then host them in a special page where, let's say, you decide to give twice a week lessons, right? So you can put one of them with a certain date, everybody passes that, then you can have a live session following it where they come together and have a discussion with the virtual instructor. And then the next one opens, and then the next one, and so on. And they'll have all of them accessible in one page. And the students who are following this, or the learners, the trainees, will not only go through those entities, not only the live sessions, but also have the possibility to do one-on-one with the virtual instructor for additional clarification. They also would have the possibility of having interaction with each other. So they can have the possibility to do forums, chats, or do small projects with each other if you choose to do that. If it's part of what you do is to do group projects, every 2-3 of them to go do some small research and come up with a report, we can do that, can be done as well. To summarize, so we took these 4 hours, we divided them to 8 lessons. Each lesson is produced in a multimedia way, put them into an interactive mode with questions, offer them on a weekly or bi-weekly basis, add them some live sessions, one-on-one mentoring, and group projects. At the end, if you want to have an online exam to give them certification, that's very easy as well. So you can create an online exam and then get a certificate as a result of the 4 hours training.
If there's no other questions, we are very, very fortunate to have Dr. Kim Akimian with us. Dr. Akimian is a professor of public health at Columbia University and is teaching there. Kim, I know you follow the situation in Armenia closely. What would you like to share with us this week about the public health situation in Armenia?
The situation in Armenia is tough, very tough. This was a graph in the New York Times, but taken from data from the Johns Hopkins University. And this is the world's worst COVID outbreaks by places. And sorry, did that stop sharing?
No, we see it.
I don't know why I can't see it though.
Oh.
You do see it, yeah?
Yeah, we see it.
So, I mean, the gray bars are various states in the U.S. So of the top 20, it's mostly the, actually 25, it's mostly U.S. states that have the worst outbreaks of new coronavirus cases per million residents in the last week. But Armenia is right here on the list as one of the countries with the worst outbreaks. Part of the outbreak data is, of course, based on testing capacity. So there are some countries that might be in here that aren't, because their testing capacity is not as robust as either ours in the US or in Armenia or some of these other countries. But I think that with few exceptions, this is a reflection of what happens when an economy reopens soon and without phases and without enforcement of social distancing practices. And so Armenia is certainly in a terrible acceleration phase, and having to deal with the chaos of all that ensues. And for those of you that are on the call and we have quite a few of you that have been in the hospital and clinic setting during the surge, you know how difficult and emotional that is. And so that's what our colleagues are going through now in Armenia. So this is as of a week ago. So these are the test rate positivity, but the thing is, Tolene, that the eligibility for a test has gotten much stricter. And you have to have had, you have to have had fever for more than 2 days, and you have to have some respiratory distress in order to be able to get a test. So
but that's
when that was
worse.
the case in New York City's case positive testing rate at some points was actually like 70% for case positive, for positive test rate. And so, this rate here is high, but it really does reflect a change of the eligibility in getting tests. So I'm not sure how to best interpret this data right now.
So what I would say, Kim, is that they are now where we were in New York. You're right. We never reached 70%. We were about 50%. But that's what you do when you don't have unlimited supply of tests, is that you have to choose who you have to test. And so if you're choosing to test the symptomatic ones, hospitalized ones, those who need care in the hospital, then that's fine. It's a good strategy. And again, the fact that we have, I don't know, is the red 30 or 25% is sustained for several weeks is concerning. And even here in the US, we are looking, yes, we have a lot of testing capacity, but it's really what percentage of tests you do test positive that is the concerning part. And for example, we know in southern states, the death rate and the hospitalization rate is lower than what we had in New York, because the percentage of tests is positive in young people, and most young people are not hospitalized and are not dying, but they might still be spreading the disease. And that's why we are very concerned about the US, that it's not controlled, because even though we're not seeing as many deaths, we have so many positive percentage of cases that means that those people are going to go and infect more and more people. So that remains my concern in Armenia, that for several weeks we've been about the same percentage. And at some point, hopefully we will come down, but obviously it needs measures to bring it down.
Right. And we may just have a lag in the death numbers too. And this, as I said, this was from, I have one more data set that's updated. I just haven't updated my slides yet, but these, by the way, to everybody who's on the call, these are graphs that are put together from data that's on websites in Armenia, but it's put together in this format by Aras Chiloyan, who is in Boston, and she just finished her MPH from BU, by the way, Dr. Babayan. And she's a contact tracer now in Massachusetts, but she's also working at Boston Children's. I don't know if you know her. So this is the case fatality rate, which again, is only as good as your denominator. And the total number of deaths in these graphs represents 453, but now that number has climbed to over 550 or 590. I can't remember what the latest data is. Yeah. So the only thing available electronically is on deaths as a descriptor is sex and age. So we don't have comorbidities or place of residence yet available to us to collate in this manner. So can you go back to the first slide, Kim? Sorry. Oh, sorry. Yeah. Is that dated all the way to the end of June, or it's the early ones we had seen a few weeks ago? Let me. So that was as of July 1st, because I presented something last week. But let me get the ones from, I think we have July 7th. Hold on one second. Sorry, guys. I didn't know if Larry wanted me to do this tonight. And yeah. So, and again, as we've said, it all depends on the hospital capacity, ventilator capacity, right? So each country, for example, in Europe, did well depending on how much beds they have available per population. So it's good that the percentage hasn't increased. So as you said, Kim, it has remained between 25 and 35%. We didn't reach 60, 70, yes. But I'm not sure what the capacity is there and whether they are reaching capacity of their ICU beds. And that will also be another super important key to
take into consideration.
Yeah, so here's the latest data. And you were particularly interested in the test positive, right?
Just the percentage positive, if it changed from the 35 or so it was earlier in June.
All right, this is
35%.
This is in that Google Doc. Let me open it up. Hold on.
Or we can do it another day if nobody.
Yeah, I know it's late for everybody, and I can show you. Yeah, it has stayed stable. You see it on the right here, right?
Yeah, but I can't see the date, that last date under the.
It's
okay. Yes,
a week ago. It was the 6th of July was the last day that she calculated them. 6th of July.
Yeah, yeah. I think I have the pictures here. That's why I cannot see. I figured it out.
That's okay. It's in the table that she put in on the right.
Yeah, that I cannot see. That's what I'm trying to see.
But if you want just to see the trend for everybody else here, it's just you know, it's just going up.
Yeah.
And these are the case fatality 7-day average deaths, and this is death by sex and by age here.
Look at how many young people they have dying.
Yeah, it's
youngish.
This is 50 to 59. There's 54, and then 151 from 60 to 69. So if you put from 50 to 70 here, there's 200 deaths, and there's about the same, a little bit more between 70 and 89. So it is skewing a little bit more to the left than in the U.S. Or in New York. Sorry, my comparison group is always New York, the New York data dashboard. And then this is the narrative one that we have this ongoing narrative slide that trying to see whether or not the enforcement of compulsory face masks and other social distancing measures, whether or not they're plateauing, but it doesn't look yet, you know? So anyway, I will stop here because it's late and I always do this. But I'm hoping, Larry, that one of these Thursdays, I'll just go through what the whole group has been working on in terms of data, data visualization and proposals for things like better risk communication, skill building, and things like that. The real crisis, I think, right now is at the primary care level, because when the country was able to monitor every positive case, either in hotel or in hospital, there was a much better sense of the scope of the epidemic. Now it's really resting on the shoulders of a relatively weak primary healthcare system that doesn't have the kinds of healthcare systems. I mean, we had healthcare systems in the US during the surge that were doing different things, but as a system as a whole, they tended to have a management leadership that was looking for ways to best mitigate the infection for their patients and their healthcare workers. Armenia just doesn't have that same strength. So, there are jewels and gems in the system, but the system as a whole, unfortunately, I think that a lot of healthcare workers are going to get sick, and I think that a lot of patients that are not COVID positive are going to become COVID positive in the healthcare system, more than needs to be. And I would call it, if we had a magic wand and unending source of funding, I would probably put it into the primary care system right now to mitigate the infections. That's it for me, Larry. You're muted. You're muted.
We always love hearing from you. Actually, we would love to have you talk with us. I know you have juggling a lot of things between your family.
No, but we're at a point now where we've put our ideas together in these buckets, and now we're seeking some funding for a partnership between the American University of Armenia and the Ministry of Health of Armenia. So we presented our ideas to the Ministry of Health, and they're absolutely supportive of them, and they want them, and they think that these are things that they wish they could be doing, but they just don't have the bandwidth to do that. And so one of the emphasis, since we've been having these conferences for the last few years discussing about ways that we could invest in Armenia in ways that strengthen the health system and that build capacity. And I really believe very strongly, and I'm happy to present this next week or whenever you have a slot, Larry, that there are ways to invest smartly in this situation in Armenia that will dovetail nicely with the other healthcare priorities and the other health policy priorities of the Ministry of Health. So, you know, issues of, for example, smoking, this is a ministry that's been out in front trying to get tobacco control legislation passed and banning smoking in public places and things like that. Well, I think it would be very powerful to know what number of cases were in smokers or what number of deaths was in smokers, and to utilize that for policy purposes, but also for risk communication and describing, you know, social media, public service announcements about smoking cessation and things like that. We just don't have we don't have the data collated. I don't even know if smoking status is something that they're collecting at the clinic level or at the hospital level, but they want this too. It's just that they want, if we can get a group of researchers in Armenia to be able to go into the system, work with the medical records organization who also wants to work on these issues, then I think we could produce things that would have long-term impact beyond the COVID crisis. So I'm happy to talk about that at another time.
Anything the ambassador wants to say? Kim, you froze.
It's okay. Oh, guys, it's almost 11 at night, and that's what ends up happening. But I thank you, and thanks to the other speakers and Rafi, really exciting. Well, he jumped off. And
I have
Dr.
a question from Dr. Zorian, if he's still with us.
Yeah, he is.
Yes, I'm here.
Let me put my video on so you put a face to the voice, as we say in this time. Dr. Zorian, first I want to appreciate all the work and the efforts you're putting with the Armenian Virtual College at the AGBU, but this is a general question which could be open-ended, and maybe this is too long to talk about it in here. But as I was checking your catalog, I didn't see any engineering technology programs in there. Have you ever thought about adding the engineering technology to your programs offered by the AVC?
Yes. It's recent. So the first 10 years of AVC, we dedicated for Armenian topics only. For Armenians, but Armenian topics only, meaning language, history, our heritage, culture. However, in the recent past, we started expanding it further. Chess was one of the domains, but technology is definitely part of it. We are currently doing two things. We are currently preparing courses for AI, artificial intelligence, that is in collaboration with NVIDIA here in Silicon Valley. So we're taking their school courses, turning them to Armenian, adding additional components to them, and so on. And we'll be offering it to the Armenian schools in the capital and in the regions. A second is for entrepreneurs who need, so these are the entrepreneurs in the regions who need to become more computer savvy. So we prepared a set of courses, initially for women entrepreneurs, today for a larger set, to make them more computer savvy. This is for business-oriented needs of computers. What we have not done yet is develop courses for actual IT, software development, and so on, which we are, again, planning to do so, but we are not there yet, okay? So I don't know if I answered your question well, but
I was more curious about the general or traditional classic engineering technology courses that could be offered, and some of them are really easy to offer online. And that's, I know you guys are very active in the IT and computer technology, but more of a traditional engineering courses, because I don't know, but you know, if it's a possibility, there are resources, there are people like me who are willing to participate and to help to offer that sort of also traditional engineering courses via online and using the technological resources to offer that.
Yeah, that will be very valuable, especially after COVID, after everybody found out the value of e-learning, the convenience of e-learning, and so on. We'll definitely have more needs for that. The engineering schools are not able to satisfy all the needs. The number of seats that we have in our industry, we have, as you know, a shortage of IT developers. We have about 4,000 open positions that we are unable to fill today in the workforce of the IT. My company suffers from that, along with many other companies. We have 63 open positions today. So we need to fill those, and the universities have a certain level that they can reach. Definitely online learning would help.
Okay, thank you very much.
I have a question for both Kim and Dr. Zorian. Kim, from a public health point of view, we know about the effects of tobacco, alcohol, drug use, and the benefits of vaccination. And a lot of these things, as children in America growing up, we just learn by osmosis. Our parents take us, we do it, and then we do that for our children, and the chain starts. Do you think there is a role, perhaps working with the Armenian Virtual College or other similar entities, to create an educational program that works with the youth? So, for example, there's this great chess program with 550 teenagers under the age of 18. Maybe during the chess tournament, there could be a 3-minute segment on the harmful effects of cigarette smoking, or why drinking is poor, why good dental hygiene is important. Basically short, succinct public health messaging, and spreading that out with our partners throughout the country. And I think this might be particularly important should a vaccination for COVID come into being. But nonetheless, the flu is coming, and vaccination rates are probably not too high. That would be another educational campaign.
Yes, I don't know. Yes, any level of you know, and the layering effects, let's say, of you know, of messaging would be great. You know, so I'd be happy to help if somebody was interested in something like that.
Yeah, I mean, technically,
Dr. Zorian, do you think that is something that?
Yeah, I think so. I think the value, you know more than me how valuable that is, but technically it is definitely doable, can be produced to short segments with creative animation and so on to go with it. I think that will be quite useful.
You know, health education is only really small piece, particularly when it comes to tobacco, but it's not harmful to have it. There are other areas of health where health education is more impactful, but tobacco, given that nicotine is one of the world's most addictive substances, and given that you know, cigarette smoking is ubiquitous in the military, and so you get really children going into the military who are finishing their growth curve with nicotine in their systems. It's extremely hard to quit. So I mean, it's nice to have these multiple layers of messaging. They're more effective in some areas than others, Larry.
Yeah. Mm-hmm. What are the most effective areas?
You know, I just happened to have this on my, where is this? Sorry.
And while Kim is looking for that, are there other questions, comments?
It just happened because I'm going to be teaching this to a seminar tomorrow. I just happened to have this open. Sorry, this is my geekiness coming out now. But this is a slide on the smoking policies in the U.S. And from 1900 until 2000. And, the first Surgeon General's report came out, so that this understanding of how bad smoking is for you came out, in the 50s and 60s. But really, it wasn't until there was, this huge federal cigarette tax right here that you start to see the decline. Is really about taxing cigarettes and banning them. From advertisements started around here, but you still didn't see a big difference. So anyway, sorry to be so geeky about that, but that's the thing about smoking. It's really about making it inaccessible by raising the price. Otherwise, once you start, it's very hard to quit. And now with e-cigarettes, and that's a big issue in Armenia, there are a lot of e-cigarette options, and it's just another way to hook you onto nicotine. And if you can't afford the e-cigarettes, then you'll go to regular old grand tobacco.
This was a great interactive meeting using virtual technology in honor of Dr. Zorian. Thank you so much. And thank you, Rafi, Avitsian, and thank you to everybody. We're so honored to have Ambassador Nesessian with us this evening. Thank you so much for joining in. And thank you for all the hard work you do for Armenia. I know right now you're working hard to help a 42-year-old woman with metastatic cancer. And we applaud your efforts in trying to help.
With your help, Larry. Thank you very, very much for all your efforts you're trying to do.
You're very welcome. There's
I wanted to use this opportunity to thank tonight's keynote speaker, Mr. Zorian, Kim, and others for their excellent presentations. Very much interesting presentations. Thank you very, very much, all of you.